So it's the same concept of relational motion. In this case, we're looking at the shoulder girdle, which really means you're going to stabilize the scapula and move the torso. So the thing that is still is the scapula, the thing that is moving is the torso. So contact is control for the hold becomes really important. So remembering that when somebody isn't seated, so first the table makes stable, less table means I need to make the patient stable. So this is as little table in contact with the patient as possible and seated. So it is now my job to keep the patient stable. Also, I need to keep the shoulder girdle stable, which means, at least in the case with somebody who has their full upper limb, you also have to stabilize the upper limb to some degree. There will be people who have less of their upper limb, and this will feel different, right? This will be different. But for the most part, you're not going to encounter it a ton. So just to be fair, to provide that caveat. Anyways, in order to control, what you're going to end up doing is, my hands do funny things. So there it is. So as I come underneath, I'm going to control the bottom. It's not going to be able to drop. I'm going to come over top. It won't be able to go up. I've got going down controlled, going up controlled. I come to the medial border. Now I have lots of contact on everything I can get with respect to the scapula and the shoulder girdle. So as I come over top, I've got the clavicle and the acromion. As I'm on the medial border, I've got the medial border of the scapula, so I can control that. Generally speaking, a yoke hold underneath here. And then as my forearm comes underneath, it just can't drop down. So the humerus can't drop down, the GH can't drop down. So I got here, we'll have you side bend away from me, right? So now it will come towards me, side bend towards me, right? As long as I keep it still, I can control that. So that's a still scapula moving torso. That's essentially what we're looking at here. We can also have rotation, so rotate to your body to the right, right? There you go, and then rotate your body to the left, right? So it's a patient active exercise or approach, still scapula, moving torso. It's not perfect, it's not the most fantastic method. However, for people who have really bad shoulders and need subtle approaches, and they're in a lot of pain, when they control the movement, they control the pain response. I don't necessarily activate a lot of tissue in and around the shoulder girdle, so I'm less likely to aggravate pain responses or excite pain responses. There will be some stretch response depending on how they move, but you can make it subtle because if they're in pain, they should control how they move. We're going to have you lay on your side, and you're going to face the same way. So you're going to put your head here on this big old pillow, right? Thank you. Now, it's not perfect because usually what's going to happen is I'm going to obscure this, so I'll do my best to not obscure this. Right, so slide back towards me. A little bit more. Sweet, there you go. So now I can control the humerus. I can stop the clavicle, or I can stop the scapula from going up with a hold like this. My abdomen can control the torso to some degree. I can get to the medial border here. Generally, not always, in lateral, a patient active approach that's not going to excite anything is going to be the patient squishing into the table. So what I want you to do is push your shoulders straight into the table and let it relax. And then it's subtle, right? So she's completely neutral. What you're gonna do is watch my hands and see if they move upwards. Okay, push right down into the table with your shoulder and let it relax. There you go. Push down on the shoulder and let it relax. Good, one more time. Let it relax. Now, what will tell you if there's some movement is when I let go, the drop, right? So I've got her to move her body in relation to the table and the still scapula. Same thing, same approach. I can have you, so I won't do that. That's cheating, I'm lifting. I'll hold it. Push your hips on the table. Let it relax. Push your hips on the table. Let it relax. Push your hips on the table. Let it relax. Okay, so if you watch my hands again, some drop, not as much. So shoulder girdle or the scapula is still. Patient pushes into the table. That moves the torso, essentially moves the torso down as she pushes down. So in relationship, if I hold the scapula still, the scapula slides up, right? So it's like I hold this still, as she pushes down that way, this goes up. So it's really more of a control exercise. Another way to do a similar hold, depending on circumstance, is here, right? So it's the same thing. I've got the acromion controlled. I've got the humerus controlled. I can get to the medial border of the scapula. Okay, so what I'm going to have you do is try to twist your torso forwards there, and then relax. The reason that doesn't work as well is because as she does it, the arm's going to engage. So I want you to twist your torso backwards, and then all that engages, so it doesn't really work all that well. Whereas if I'm here, squish your shoulder on the table, let it relax, squish your shoulder on the table, let it relax, and then as I let go, there we go, we get a drop. So same concept, relational motion, patient active. I choose to keep this still and move the torso in relation to it in both seated and in lateral. You can do this in other positions, it's just way harder. So supine and prone, it's much harder to do this. Aside from in supine, you can have them push back into the table with the opposite shoulder and it will work sometimes, just not as much as you would want it to. These are the two positions where it's going to do more.